This is Vic Rao. I'll be talking about the abdominal aortic aneurysm screening using ultrasound. Very briefly, just going to cover the anatomy, how to diagnose the condition using ultrasound, and the screening indications, as well as scan technique, the views required when you're doing this procedure, and the correct method of measuring the abdominal aortic diameter or the aneurysm diameter, and some pitfalls so that we don't encounter any mistakes while doing this procedure, and other modalities to consider when ultrasound doesn't work. Very briefly about the anatomy, as you can see, this is the abdomen. You have all the structures moved. You can see the abdominal aorta and IVC. The abdominal aorta is entering the abdominal cavity through the aortic hiatus, and in males, the diameter is a little bit more as compared to females. As it progresses down towards the umbilicus area, the level umbilicus, where it divides into the left and right common iliac arteries. And you can see here that the diameter and the bifurcation level at this level is much lesser as compared to the aortic hiatus level, which was like 2.7 males and 2.3 in females, and for males it's 2.1 and 1.7. Very briefly about how we distinguish or differentiate between the two vessels. Aorta is going to be towards the left of the midline on the image. If you see in the ultrasound image, it's going to be displayed on the right side, and the IVC is going to be right at the midline. It's a thin wall structure. Aorta is much thicker walls. You can even see the layers in thin individuals. Roughly, it's going to be circular in cross-section, and we'll be showing pulsatility. If you do a Doppler, if you're not so sure, you can do a spectral Doppler, and you can see pulsatile flow. And you can also appreciate the blood vessels that are rising from the aorta. What is really an aneurysm? It's nothing but the dilatation of the abdominal aortic wall. Here you can see a common type of aneurysm that you will encounter, which is known as the fusiform type of aneurysm. You can see here, this is a long axis view, that's the spine. And you can see this is the lumen of the aorta. And you can see here the wall of the aorta is kind of dilated, just like a garden hose. So it's just dilated over here. And this is where you want to measure from outer wall to outer wall. And here's another example, which is not that commonly seen, which is the saccular or the barrier aneurysm. You can see it's just like a little outpouching, but it's not uniform increase as compared to the fusiform type. In this case, of course, you will be measuring from outer wall to outer wall, and from here all the way up to here. So look at some data, and you notice that this is primarily disease of older individuals, and typically is going to be smokers over the age of 65. Interestingly enough, you see something from the CDC, which shows that the contributing cause of deaths in 2009 was about 17,215. And it's definitely dropped in 2014 to 9,800. So you see that's because of the fact that folks have been doing lots of AAA scans with the ultrasound and be able to diagnose the condition and intervene and fix the problem. And so the USPSTF recommendation is that AAA screening should be done in individuals 65 to 75 with history of smoking, even if they're asymptomatic. That is very important to understand that it is not always symptomatic. The patient could be having no symptoms whatsoever, and they could be having a silent AAA. So it's very important to be. Another thing to observe is that 95% are going to be below the level of the renal arteries. So other risk factors that are there: male, Caucasian, smoking increases the risk 3 to 5 times, hypertension, high cholesterol, atherosclerosis, COPD, peripheral aneurysm disease or Marfan syndrome, first order relatives with AAA. And this is a new warning by FDA. So fluoroquinolone is actually supposed to increase risk. So especially if the patient has these pre-existing risks, then you should avoid giving this, because you can actually increase the risk of AAA. Screen indications: men over 65, females over 60 have cardiovascular risk factors, family history of aortic and peripheral aneurysmal disease, Could be history of smoking, hypertension, of course, first-degree relatives I just mentioned earlier. So other indications that are not part of the regular one would be somebody who comes in then to the outpatient clinic or the ER with a pulsatile abdominal mass. I have an interesting case that will be showing towards the end of the presentation. It was presented, and we have unexplained lower back pain, especially new onset. Could be peripheral aneurysm disease that was found. Imagine you send somebody for a DVT scan, and it was reported no DVT seen, but aneurysm was seen in the popliteal artery. Well, then you should be thinking of a possibility of an aneurysm elsewhere, and a good one would be area to definitely look for would be the abdominal aorta. So abdominal pain in the groin. As you can see, they're very non-specific, but you should be kind of looking, and also as a part of the follow-up, if the patient did have an aneurysm 3 centimeter or more diameter of the abdominal aorta, you want to definitely follow up and see, because aneurysms will tend to generally grow in size with time. Why the screen is important is because large aortic aneurysm can rupture or leak, and of course dissection can also occur at the same time. I have some images I'll show you that will help you understand that process. And of course the mortality rate is very, very high, so you definitely want to intervene before they rupture or the leak, and also the complication rates are also much higher. So potential complications would be rupture, hypovolemic shock, patient-present shock, IVC compression, because IVC is just next to the abdominal aorta, so the blood clot can put a lot of pressure on the IVC, and it being a low pressure system, it can collapse. And so we have obstruction of ureters, they're also running on the sides, and so they could cause hydronephrosis, distal embolization could occur, AV fistula formation, of course, death. Here's a schematic showing, risk of rupture. So you can see here, when it's like 5 to 5.9 centimeters, is 3.3 times increased risk. When the diameter goes to 6 to 6.9, suddenly you see there is almost a 3 times more increase in the risk of rupture. And then, of course, when we go from 7 to 7.9, then we have 24. You can see this is actually almost 8 times the risk. So there's another thing to be understood is something called Laplace's law, and that explains it why this happened. Because if you look at the wall tension, it's actually connected directly to the internal pressure, which is the blood pressure, and the radius. So the more the size or the diameter of the abdominal aorta or the aneurysm, the more the risk is there, because directly related to the wall tension is going to increase significantly. And therefore, so what we can, when imagine this patient, what we can definitely do is reduce the patient's blood pressure or maintain at least the hypertension. There is something to be aware of called as a Glasgow Aneurysm Score, or GAS. This would be if a patient presents with abdominal aortic aneurysm leak or a rupture, and this kind of helps us understand what sort of mortality we can expect. And so GAS is, if it's more than 85 in total score, would predict a much higher mortality than someone who's much lower. So what would we have is, first we have the age in years, say somebody 65 or 70, and you can see added patients present with shock, then that already has increased. The patient present shock, that already has a very low predictive value for about better outcome. And of course, a pre-existing myocardial disease or cerebrovascular disease, and of course the patient has renal disease, get numbers you have to add on, and that's going to determine what's going to happen to that patient as an outcome. So when you perform the scan, you have to do a fasting overnight so that you can be able to see unobstructed view, preferably, of the abdominal aorta. If you're planning a barium study, definitely you want to be able to proceed, because you don't have the patient swallow barium, because that can obstruct. An ideal time to scan would be early morning. Of course, patient comes in emergency setting, we can definitely perform the ultrasound anytime. Patient supine position, you can bend the knees, that will help relax the abdominal wall and be able to press down, and also you can compress and wash the bowel gas to move to the side to be able to get a nice clear view. So there are 6 views that are required at the minimum. we'll have the upper abdominal aorta. You can have the probe marker point to the patient's right side and identify the spine, adjust your depth to have the spine and spine shadow. And just enter to that, we'll see on this side, we have the aorta, and that's going to be the IVC. So just see, and the definition of upper abdominal aorta is actually at or above the level of the celiac axis. So the celiac artery, identify that, and you have to go higher than that. And so anteriorly, you should see the liver. So we know that, and also make sure your depth is adjusted well, so you're able to see the structures without cutting it. This is the view to the mid-abdominal aorta, and in this level, you will definitely see aorta in the spine, and just measure outer wall to outer wall. If you do see an aneurysm or dilatation, you want to also measure side to side, because sometimes the diameter could be much more on the side lateral aspect as compared to anterior posterior, and the management is based upon the maximum diameter that we get. Here's the transverse view to the lower abdomen. You can see just above the umbilicus. So if you do the umbilicus, you may see the bifurcation, or maybe it might appear oval. So go a little bit above until it becomes circular, and then you measure the AP diameter. That's very simple. And as you look at this image here, since the probe marker is pointing to the patient's right side, and this marker corresponds to this marker here, so this is representing the right side of the patient, and this is representing the left side. We also have to get the corresponding long axis or mid-long axis view through the middle of the abdominal aorta. How we know it's when we just sweep the probe side to side along the aorta, we will notice that you will start seeing the intima and the media adventitia. When you see that, then you know clearly that is going to be your the mid level, because that's when you'll be able to see these layers of the wall of the aorta very clearly. And of course, this is a spine, this is vertebral bodies and its vertebral disc spaces. And just observe here, there's the liver in front, and this is the celiac axis, which is the first vessel that you will see arising. And the next one would be the superior mesenteric artery, which runs parallel. Sometimes they are kind of coming from the same origin, but they could be separate too. So anything from celiac axis all the way to the aortic hiatus, that is considered to be the upper abdominal aorta. And we want, when you measure this, you want to be aware that it's kind of diving deep. So you want to be coming perpendicular like that. So outer wall to outer wall, and not kind of measuring obliquely, because then you can actually have a false positive. This is the mid-abdominal aorta area. You can see very clearly, beautifully, you can see the vertebral bodies, and you can see the intervertebral disc spaces, and of course you can see the abdominal aorta. And another thing to observe is, as you're going down towards the level of the bifurcation of the lower abdominal aorta, you notice that the aorta is actually becoming more superficial because of the curve of the spine. And you can see here that this is getting much more superficial. You may have to adjust your depth. And again, where would you measure? Where the diameter appears to be the maximum. So where it appears dilated, so you just can measure outer wall to outer wall. This is the view showing the longitudinal view to the lower abdominal. You can also appreciate this is a slightly oblique view. You can see the two common iliac arteries here, and this is again outer wall to outer wall. So here's the patient with an aneurysm, and of course this is the normal aorta diameter, and this one is the one with the aneurysm. You can see we are measuring outer wall to outer wall. Be aware that whenever there's a large aneurysm, there may be a circumferential clot inside. And so this is a patient which actually was provided by Dr. Steve Burns. You can see here, this is the correct way of measuring. And in fact, this was reported as not an aneurysm because somebody accidentally just measured the lumen. So never measure just the lumen, it's of no value. What is more important is the diameter of the abdominal aorta. And when you do see aneurysm, you measure outer wall to outer wall. And of course, what is more important here is the bigger diameter is 7.6 is transverse, and longitudinally we have 8.1 centimeters. Be aware that you have to have the correct settings. So if you have a patient, you're scanning and you see that the gain is too high. This is a patient you're scanning and then the gain is so high, you can see that you can barely tell where things are. So make sure that your settings are right. and so you're able to see the structures clearly. And of course, this one also you can see gain is too low, so the overall image looks really dark, and your TGC or time gain compensation, which is the selective level, brightness again or darkness, also be also adjusted uniformly so that you're able to see the image very clearly. So how would you go about diagnosing? Of course, a positive finding would be a patient who has an abdominal diameter of 3 centimeters or more. If you have a short statured individual, they recommend, for instance, somebody who's really short, like 4 feet tall, or maybe less, and then you want to get their normal abdominal aorta diameter, the proximal abdominal aorta, and which is provided as normal. Imagine that was 1 centimeter. Then for that individual, it would be 1.5 times that diameter. So that would mean for that person, it would be 1.5 is the cutoff. But normal adult males, we talk about 2 centimeters. So 2 by 1.5 is like 3 centimeters. That's why 3.0 is considered as the cutoff. Anything less than 3 is obviously going to be labeled as normal, but we expect things to be, the diameter to be about 2, 2.1, 2.2, but what is 2.7 or 2.8? That would be considered ectasia. That means it's not normal, but it's not aneurysm yet. So this is considered an ectasia or just a dilatation. Here, if what will be indeterminate, sometimes when you scan, you may have difficulty viewing some segments of the abdominal aorta. So if you're not able to see the abdomen at a certain length, then you're not going to say there's no aneurysm because you've not even seen it. So we call it indeterminate. That means we plan to either follow up and try to rescan the patient, or if we feel that, say, the patient has impossible, the patient is really obese, you're unable to see the abdomen at all, or something just not going to be visible, then you want to get something, consider something else like a CT scan, because especially if you're considering that the patient is very high risk. In the AIUM guidelines, we have an interesting number. I just put it out here so that if you ever encounter that, you may not be confused. So they talk about the upper abdominal diameter to be reported as aneurysm if the diameter in the males is more than 3.9 centimeters, not 3.0, and females is more than 3.1. But a lot of institutions are just going with 3.0. This I just put in there so that in case you ever see this, you don't want to be confused. But even for them, the AM guideline, the mid and the lower abdominal diameter of 3.0 or more is considered to be aneurysm. It's just for the upper abdominal that they have a slightly different criteria. The follow protocol, this was published, and you can see every organization might have their own protocol, but you can see here 3 to 3.4 is every 3 years, 3.5 to 4.4 at 12 months, and then 4.5 to 5 to 6 months, and then of course 5.5 is a very high risk of rupture, so definitely you want to refer to the specialist. One more area that you need to understand is one more thing, that's you do see plaques, and those may make it difficult to measure the abdominal diameter, especially if its anterior wall is having a lot of plaques. Aortic dissection could be an issue. You could see that. You could see leaking aneurysm, but sometimes aneurysm leaks may not be seen on ultrasound, so you should be aware of that. You would better consider a CT scan. And of course, tortuous abdominal aorta, very important. If the patient's abdomen is tortuous and you just did a transverse view, as you look at this, you actually gonna falsely create this and call it an aneurysm, whereas the true diameter was this. So be aware that you should, when it's tortuous, and how do you know it's tortuous? You're not able to get a long axis view. No matter what you do, you're just not able to get a long axis view. So definitely be aware of that. Other incidental findings, you may get an X-ray for a backache, and you see it's a little something that's suggestive of a calcified wall of the aneurysm. Here it is. You can see CT scan was done, and you can see clearly opacified lumen of the aorta, and of course there is a large thrombus. So thrombus is going to be part of the aneurysm. You will never see an aneurysm without clot if it's large size. Other things to consider, lymphoma could be there, parietal lymph nodes, horseshoe kidney, as I just mentioned, tortuous abdominal aorta to be aware of, and failure to identify thrombus, and then failure to measure correctly. Here's a patient with a horseshoe kidney, and color Doppler will be very helpful. You can see color Doppler on. You'll see this lighting up, so you know that this is a vascular tree of the kidney. So clearly, this cannot be a thrombus. This is a patient with a ectopic or a horseshoe kidney. Here you can see this is a case of a dissection. You can see something flopping in there. Do a long axis view. You can see the true and the false lumen. And this is a CT scan. You can see pacification of the true channel. And this is the thrombus right here. There's no flow right here. So indication of repair is any aneurysm diameter of more than 5.5 centimeters. And leaking aneurysm, of course, rupture aneurysm, and of course, the patient increase in diameter is more than 10% or a tender aneurysm. They will all call for repair. There are two options. You could do open repair or you could do endovascular, which has a much lower perioperative mortality, 1.5% as compared to 4.5% as reported by this study that was done. So final points are that the abdometer is retroperitoneal structure, and ultrasound is very good at diagnosing the condition. Keep in mind, the patient may not be symptomatic all the time. This patient could be totally asymptomatic, it could be a silent condition, or could be having some non-specific pain, back pain, pain in the groin area, or the patient could present with shock. And so that is something to consider. When patient comes in shock, definitely want to make sure that they don't have an aneurysm that is ruptured. And of course, if you see an aneurysm, you want to measure outer wall to outer wall. If there is thrombus in there, be aware. One thing you can do, turn the light off in the room. I have low lighting conditions, so you can actually appreciate the aorta and the lumen and the thrombus. And be aware that 95% are infrarenal. So that's the good news here. Upper abdominal is generally is hard to scan because of the bowel gas and other issues, and also is deeper. Be aware of other conditions that might look like an aneurysm. I'm going to wrap it up with a very interesting case. It was presented and published in the New England Journal of Medicine by James and Joseph. And you can see here, they saw a patient who had a painless, visible abdominal mass and 40 pack years smoking, large non-tender pulsatile mass was seen, and it was 15 centimeter in diameter, and was finally repaired with Dacron graft and had a steady recovery, patient was discharged. To give you an idea about what 15 centimeter is I just took a picture of a dog with a 15 centimeter ball in the mouth. So you can see, you can appreciate how big that was, but this doesn't do justice. Let's look at it on the patient. It was so big that you can see this huge mass, pulsatile mass, bulging out through the anterior abdominal wall, and also is pulsatile, so it's moving as the patient's heart is beating. So clearly, you should be thinking of an aneurysm if you see something like that. At least rule that out.